Welcome to the PNOC Informational Webinar for Pediatric Medulloblastoma, our fifth pediatric disease-specific brain tumor type webinar in the series. I'm Bruce Campbell.
And I'm Alan Campbell, and we helped co-found PNOC Foundation in 2013, 3 years after our son was diagnosed with a brain tumor.
Welcome and thank you to viewers joining us from all over the world. Today, you'll hear from world-renowned PNOC doctors specializing in the treatment and research of pediatric medulloblastoma about the current state of research, clinical trials, and the latest in treatments for this tumor type.
And you'll also meet a patient family and hear their journey as well as their insight. And today is really about information sharing. We have families joining us that are newly diagnosed, and we have families that have been dealing with this disease for quite a long time. And we want to hear your questions. We want to get them answered. So we encourage you to please post them in the Q&A and not the chat for our panelists.
For those of you joining us for the first time, the Pacific Pediatric Neuro-Oncology Consortium is now the world's leading pediatric brain cancer consortium, comprising of over 225 doctors, researchers, and principal investigators with sites in the United States, Canada, Europe, India, Israel, Australia, and New Zealand, striving to improve treatment outcomes through a uniquely collaborative approach, translating the latest findings in pediatric brain tumor biology into clinical trials and better treatment outcomes. A key mechanism to support this translational research are these unique PNOC working groups, which pair doctors and researchers from around the world with specific brain tumor type expertise and focus. Through scientific consensus and collaboration, the most promising ideas are then translated into clinical trials, and advocacy and philanthropic groups are invited to participate and lend their perspective and expertise.
Very unique, yes. PNOC Foundation is a nonprofit public charity really designed to help lead fundraising, awareness, and support for the scientific consortia, and really to allow the doctors to do what they do best.
Without further ado, it's my honor to introduce our distinguished panel. Dr. Tab Cooney, Assistant Professor of Pediatrics at Harvard Medical School and Director of the Stop and Shop Family Pediatric Neuro-Oncology Outcomes Clinic at Dana-Farber Boston Children's Cancer and Blood Disorder Center. Dr. Robert Wechsler-Reya, Professor and Director of the Tumor Initiation and Maintenance Program at the Sanford, Burnham, Prebys Medical Discovery Institute in La Jolla, California, and Director of the Clay Center for Neuro-Oncology and Genomics in Rady Children's Institute for Genomic Medicine.
And we also have Dr. Sarah Leary, attending oncologist, medical director of the Seattle Children's Brain Tumor Program and Professor of Pediatrics at the University of Washington School of Medicine. We also have Dr. Shannon Lundy, pediatric neuropsychologist, associate clinical professor, Department of Pediatrics, Director of Psychology Services at UCSF. In addition, we also have another esteemed doctor joining us to help kind of answer all of your questions today. We have Dr. Sabine Mueller joining us, PNOC co-founder and project leader. She's also assistant professor of clinical neurology at UCSF.
And last but not least, with Rachel Cassells from PNOC Foundation, who'll be helping to moderate the Q&A today.
And then we also have a patient family, Barbara and Steve Karsky joining us, and they'll be sharing about their daughter, Mila, and her journey.
So in summary, you've got a powerhouse panel to actually address medulloblastoma today. So I'd like to turn it over to Dr. Robert Wechsler, who'll kick us off by taking us to some slides and giving us an overview of pediatric medulloblastoma.
I got that. Okay. So thanks so much, Bruce and Alan, for the introduction, and to the PNOC Foundation for putting on this really fantastic opportunity for discussion of medulloblastoma. I also want to thank my co-panelists and all of you for joining us. This is really a privilege, and I hope that we can share information with you and answer your questions over the next hour to hour and a half that will make this really informative and really valuable for you. So you've already heard the introductions to the panelists. We just have a few slides and we're going to tag team, and then we're going to stop talking at you and try to answer your questions. So just to bring everybody up to speed, medulloblastoma is the most common malignant brain tumor in children. This is an extremely aggressive disease that, if left untreated, will grow rapidly and spread through the nervous system. As you'll hear in a minute, we rarely leave children untreated, but rather treat them very aggressively, and there are consequences to that as well. And when we think about medulloblastoma, it's no longer appropriate to think about this as a single disease, but rather as at least 4 major and maybe 12 minor subtypes of this disease, all of which occur in the back of the brain and the cerebellum, but each of which has distinct molecular characteristics, distinct patient characteristics, and distinct outcomes. As I mentioned, treatment is usually quite aggressive and includes surgery to remove as much of the tumor as possible, radiation, except in the case of very young kids, and combinations of chemotherapy. And Tab, I think I'm going to turn this over to you to talk further about the treatment and consequences.
Thanks so much, Rob. So if you're listening to this and you're within North America, you're probably already aware that there's a few different medulloblastoma protocols out there for upfront strategy, and when to introduce radiation, how much radiation is influenced by the age of the child, the neurodevelopmental stage, and how risky the medulloblastoma is deemed to be. We could get into some of those details later on if the group has questions, but you all are probably well aware that we try to cut out everything that we can see that's disease and incorporate multi-agent chemotherapy and radiation for most of these children. You go to the next slide.
Yeah.
So to reinforce what Rob said, the molecular subgroups really are the strongest factor to help decide just how aggressive these tumors are. We have Sarah here, who's co-chair of the CNS committee for the Children's Oncology Group. She could certainly explain a lot of the COG trials that have happened recently and will continue to happen. This was on the left, the results of the standard risk medulloblastoma COG protocol, ACNS 0331. What we're showing you is that generally speaking, for standard risk medulloblastoma, the long-term overall survival is now at least 70, 80%, and that's been a big improvement over the last few decades. But we do say that with humility because it's not 100%, and it certainly needs to be. On the right, we're showing you recent data from a resource-limited country, just reinforcing this realization that the molecular subgroup, even when we're talking about other countries, is the strongest prognostic factor. And as it turns out, in resource-limited countries, group 4 medullo and sonic hedgehog still largely does very well, but there's much poorer survivals for the other subgroups. So what's key is to get them access to the right treatments, the same treatments. Every child deserves the best treatment possible, no matter where they are on this earth. And if radiation is in the treatment plan, to try to minimize the delay to that as best as possible. So we can talk about, the therapy that has happened over the last couple of decades and what we know of that toxicity long-term in the next slide. And Sarah, if you want to jump in now, please feel free.
Yeah, absolutely. I mean, I think some of again, I will echo what Tab said about progress and also humility. The way to date that we've been able to improve survival is exactly as mentioned. And these are 2 examples that have come in my sort of what have we learned in the last 10 years. There are still groups of children, and we can define them better, who do benefit from more intense therapy. And these are 2 examples of data we've just gotten in the last few years. The one on the left is actually showing the benefit of giving carboplatin daily during radiation, and it was exclusively in children with group 3 high-risk medulloblastoma. This is actually something we would have missed potentially had we not already been thinking of medulloblastoma as the 4 subgroups, which is something we adapted the trial to midway through, because it takes 10 years to do a trial. It's very important that we have this constant interaction between, understanding of the biology as well. So even though the trial wasn't studying very exciting or new medications, because of the biology, it was able to inform who would benefit from more intense therapy, and most importantly, actually, who doesn't benefit from more intense therapy. And then the graph on the right, which is showing, and for any of those who are not used to looking at these, we as clinical trialists look at these kind of graphs all the time. You basically want to be that flat curve at the top, which means everybody is alive as you go across time. And thanks that's Rob's pointer. That said, there is no good tumor, and I can't say this enough, that we are not talking about good and bad tumors when we talk about cancer of any kind, but we're talking about different types of tumors that allow us to pick the best treatment for each child with all the information we know so far. And a lot of the frustration is what we don't know yet and how long it takes to get information. So that the curve on the right is actually showing two curves, the bottom one, which is blue, and the middle one, which is red, showing how one additional medication doubled the survival for that small group of children that were on the trial. And again, this is another cytotoxic medicine, methotrexate, which we do not want to give to everyone. The curve at the top, I will say, is an example of 100% of a small group of kids with hedgehog, who we might argue are in fact overtreated. So it's great that they have all of the kids on that trial that had that group survived, but we would therefore like to give them less toxic therapy with fewer long-term side effects. So if we go to the next slide, I think I will just mention that I
interrupt you for 1 second, because there's a question directly to that slide. So
sure.
Which trial this is? I think.
Oh, I'm so sorry. Yeah. So these two trials are the other ones that were not mentioned by Ted. This is the higher on the left is the ACNS 0332 high-risk medulloblastoma. On the right has only been presented in abstract form yet, but it has been presented at some national meetings, is the ACNS 0334. So these are both 10-year, in addition to one Tab showed for standard risk, 10-year trials that were done. All of the PNOC institutions in the US and Australia are also members of the Children's Oncology Group, where we run and have traditionally run very long upfront trials of chemotherapy. But yeah, they're both from Children's Oncology Group trials. And so again, we cure most kids with cytotoxic. I will tell you all those curves that aren't, 80 sounds sort of like a good number, but that means we're still losing 1 out of 5 kids. And it's this constant balance of did we undertreat or did we overtreat when we're talking about toxic therapy. And so there are many of the side effects are from radiation, although chemotherapy is not without side effects, but we spend a lot of time, particularly with medulloblastoma, about thinking of how to give radiation to the smallest field and at the lowest dose that can be curative. And it's because of these long-term side effects that we really are focused on that. And the older I get, the less I feel comfortable giving radiation. So it really has been a push across all of our careers to say, what can we do that will not only cure the kids, but be less toxic long-term. And I think if we go to the next slide, I will turn over to Dr. Lundy about really the specifics of how we're trying to look at these important outcomes.
Thank you all for joining us today. It's really an honor to be here, as the other panelists have shared. We really appreciate you all taking the time. As Sarah just mentioned, we do know that there are some negative side effects associated with treatment, and in particular for brain tumor patients. Not that chemotherapy is not toxic and can cause some late effects, but certainly radiation has a pretty significant impact on overall neurocognitive functioning, particularly in younger children. And we really also want to recognize that what happens, especially for the cognitive and also the psychosocial piece, they aren't necessarily seen right away. So physical and sensory deficits can be seen right away, but the neurocognitive kind of tend to happen through the course of development over time and emerge as children are expected to make more increasingly complex cognitive tasks happen for them, and that can be very, very hard. And unfortunately, we don't really know at this point still who reliably in advance are going to develop more significant late effects and who are not, because even with radiation itself, we still don't know who's more at risk and who is not. And so certainly there are some premorbid genetic factors that play a role in that we need to pay attention to. So there are premorbid or a family significant history of things like dyslexia, ADHD, anxiety, depression, things like that, then we know children are potentially more prone, but also the location, the size of the tumor, how complete the resection could be, what the radiation field is going to look like, complications from surgery, all of those things really do play a role. And then also for just the family in general, how much they're able to cope with and handle. Those are all factors that have to be taken into account. From the literature in general, we know that there is a core set of cognitive processes particularly impacted in pediatric brain tumor patients who receive radiation. That's attention, working memory, processing speed, or just kind of processing information efficiently and effectively. And what happens is that these challenges as cognitive tasks become more complex over time in development, children can really have a slowed learning curve across different domains because it's becoming more challenging to keep up with their peers. And another piece that's so important is the overall quality of life. And there are so many things associated with treatment and just this type of diagnosis that are really difficult for patients and families. Very common feelings of anxiety, depression, fear, isolation, post-traumatic stress syndrome. They're very real, and these happen to a lot of our patients. Also, just from an overall social perspective, self-esteem, interacting with peers in the same way that a child once did. Those are all can look very different after treatment than how a child was before. And so really thoughtfully monitoring those symptoms and being aware of those kind of changes is really important. And so we really recommend neuropsychological evaluations at specific time points to be able to watch and follow children across development. The Children Oncology group has a set of guidelines that's pretty common across most medical centers in terms of wanting to try. It's really almost impossible to catch a baseline of functioning because children are so sick at the beginning, but following treatment, anywhere from 6 to 12 months after treatment, is a good time to get some sort of a baseline. And then really after that, we try to monitor kids every 2 to 3 years, especially as they meet specific developmental milestones in the academic setting that we know are going to be met with new cognitive challenges. So there's a saying of from the transition from 3rd to 4th grade, for example, you're no longer learning how to read, but you're reading to learn. There's a huge shift when you move to junior high and have multiple teachers and classes. The executive function system is now required to do a lot more than has ever been asked of it before. Transitions to high school are big, and obviously college, and just getting ready for school in general can be a big adjustment for little ones. And so we really want to make sure that we have all the supports in place at school to ensure that they can have success, but also we want to monitor overall emotional and behavioral adjustment so that we can do what's needed for the child and or the family system to make sure that they're well supported. There are some things in the literature right now, certainly school support through IEPs, getting physical therapy, occupational therapy, speech and language therapy as needed are all really important. Certainly working with different kinds of tutors if possible for family systems and or working with different community agencies and things like that. Those are all things that through these evaluations, we're able to connect families with the kinds of supports and services that they need depending on the child. And we really try to tailor them because it is really child specific. And then there are some broader things that can potentially be done. I mean, there are some cognitive remediation programs where one skill or a very small subset of skills is looked upon, and there is a multidisciplinary team, usually the school, physiatry, clinical psychology involved, but these programs are very rare. There's not very many across the country, and they're very cost prohibitive. So at this point in time, that's not really something many people can access. There are some computerized training programs that people often ask about. And although they have things like CogState or CogMed, Luminosity, things like that. And certainly these programs do a good job of kind of teaching and kind of consistently presenting a certain type of task, and children can improve on that. And there is some hope that in certain domains like attention, things can get a little bit better, but the generalizability from a research perspective of this to day-to-day life and making it happen in other settings and across different types of experiences and situations has not really been yet something that we can prove. And then there are some pharmacological treatments, particularly for attention, but then there are also some different kinds of medications being used right now that potentially can help with executive function and memory. Aricept is right now, there's some very preliminary data being shown that can be helpful. Metformin is also a type of drug that might do some brain repair. And there's a clinical trial underway at the hospital for sick children regarding that. There's modafinil is something that could potentially help with just overall general fatigue. And so there are some very small trials being done right now to see what can be done, because we know that the impact is so significant from a cognitive perspective, but there is nothing yet that is just kind of standard of care or routine care. I think too, this whole piece from a psychological perspective is so important. And so connecting with your team to ensure that you're getting the support from a developmental perspective is something that we all are here for and really want to encourage families to reach out to those that are working with you and your child so that these supports can be put in place. And at PNOC in general, we are really trying to integrate neurocognitive screening, quality of life measures into all of the trials so that we can have a better appreciation and understanding of who's more at risk and when these things start to show up so that we can more proactively decide how we can intervene more quickly and or just be able to better appreciate and understand what kinds of compensatory strategies and supports need to be set from the very beginning for certain patients.
Great. Thanks, Shannon. I think we'll move on. I guess the next slide is me. And I could certainly talk for an hour or more about areas of biologic investigation, but I will, rather than that, give you just a quick flavor of what's being done in the field, and then certainly happy to answer any questions you have. So I think one of the keys over the last 20 years to being able to understand medulloblastoma and then develop better treatments comes from using animal models to try to understand the disease. And there are a variety of types of animal models, but these have been incredibly informative in terms of answering some of the fundamental questions about medulloblastoma biology, which have in turn led to better understanding and new approaches to treatment. So for example, these models can be used to ask which normal cells in the brain are the cells of origin, the cells that give rise to the tumor. And that's important because if you understand the cells from which the tumor arises, you can begin to develop appropriate treatments that for example, target the tumor, but not the corresponding normal cells, or take advantage of a feature of the normal cell to develop a strategy for treatment. Certainly, there's been a tremendous amount of sequencing of the DNA in the nucleus of tumor cells, the RNA that's sort of the transcript of that DNA that's specific to a particular type of cell, and the epigenetic changes, which are the marks on the DNA that dictate which genes get turned on and which genes get turned off. And so we have a huge literature now on what genetic mutations occur in medulloblastoma. And the big and ongoing question is which of those genetic changes which we've discovered to occur is actually a driver. Which of those mutations are capable of turning normal cells into tumor cells? Because those are the mutations, those are the genes that we want to target with our therapies. If we can reverse that process and turn a tumor cell back into a normal cell or kill the tumor cell entirely, those would be strategies for therapy. So we can ask that from the standpoint of sequencing of the DNA and the RNA and the epigenome, but we can also empirically test different therapeutic strategies. And I'll tell you in a few minutes about a strategy where we can test hundreds or even thousands of drugs to see which ones of those kill tumor cells, at least in a dish, and then try to translate that into which drugs might be useful in the clinic for a particular patient. And of course, there's been a huge revolution in many different cancer types of using the immune system to try to target tumors. This is a very old idea, but has really only been deployed successfully in the last decade or so. And there have been remarkable successes in melanoma, in skin cancer, and in lung cancer and some other diseases. There are promising rays of hope in pediatric brain tumors, but we still have a long way to go to figure out how to use immunotherapy to really target tumors. And so among the many questions that are being asked by scientists in the field are these, and also questions about metastasis and what controls the dissemination of tumor cells into the brain and down the spinal cord. And so I think that there's now a very large and very collaborative community that's studying medulloblastoma, and together we've made quite a bit of progress, but we still have much further to go to be able to bring those discoveries to the clinic. So there are a number of clinical trials that are underway or have been recently started for medulloblastoma, 3 PNOC trials that that focus on medulloblastoma or include medulloblastoma patients are PNOC 05, which uses a modified measles virus for treatment of children with recurrent medulloblastoma or recurrent ATRT. PNOC 016, which uses a really unique drug called fimipenostat, which targets 2 different pathways. And this is being tested in children and young adults with DIPG, medulloblastoma, and high-grade glioma. And then PNOC 027, which I alluded to a minute ago, which takes advantage of drug screening as well as genomic testing to identify individual treatment plans for children and young adults with relapsed medulloblastoma. And I just wanted to give you a glimpse of what this looks like. This is the newest trial. It's focused on medulloblastoma. It hasn't yet opened, but we're hoping that it will launch in the next month or so. As I said, it uses a multimodal approach where we capture tumor tissue from a patient at the time of surgery, at the time of relapse. And we subject it to a number of different kinds of analyses, including sequencing the DNA, sequencing the RNA, looking at the epigenome, and doing this high throughput drug screen where we test hundreds of drugs to see which ones of those drugs kill this particular patient's tumor cells. And then we take all of these data, which are available within a couple of weeks after the surgery, and we convene a molecular tumor board that consists of oncologists, pathologists, surgeons, computational biologists, basic cancer biologists, and we all get together and we discuss the data and try to come up with a treatment plan. This is a really novel approach. There are certainly other trials that take DNA sequencing and even RNA sequencing and use this as a basis for determining therapies. But this notion of empirically testing drugs to see which ones work on a patient's tumor is really novel. And we're hoping that it's going to change the way that we approach treatment of kids with medulloblastoma and other diseases. So I think those are all the slides. And if the co-panelists have any further comments, this would be a good time. Otherwise, we can open it up to questions from the audience.
Thank you, Rob. Rachel, do we have any questions coming in right now?
Yes, so we have a question. How do you run the drug screening on the tumors for PNOC 27?
So we started this process in San Diego at Rady Children's Hospital. And when we started it, we were doing the drug screening in my own lab. We would get cells, we would get tissue from the operating room, bring it back to the lab, make a suspension of cells, and then put them into a dish that had hundreds of different drugs. With that working quite well, we decided to collaborate with the University of Washington, which has a clinical drug screening facility. And so we're able to take cells from the surgically resected tissue and ship them overnight to that facility in Seattle. And then they perform the drug screen immediately. And within 3 or 4 days, they send us the results. And essentially for that screen, we test 175 different drugs, many of which are FDA approved and therefore can be used, can be prescribed by physicians. And we simply look to see whether the drug kills the tumor cells in the dish. And with all of those data, we can then have a discussion about which of those drugs would be appropriate to use in a patient.
Okay, great. I have a couple more questions. Is that kind of drug screening being used for adult cancers also for chemosensitivity that you know of?
Yeah, so it was the facility at the University of Washington was set up by a hematology oncology professor who was doing this in the context of leukemia. And they have since done it in the context of other adult cancers. This will be their first pediatric cancer trial.
Great. And one other question, which I think is a great one, and I think we struggle with this a lot, is is something like this, which is highly innovative and requires a lot of coordination, also available outside the US. So this was a question if that specific trial would also be open in the UK. And maybe I can answer this and you can chime in as well. For now, we are just piloting this because it's a very novel strategy. There are efforts also in Europe that are using this. In Germany, for example, the team in Heidelberg, as part of their larger INFORM study, where they're also offering sequencing of tumors, also have now integrated this in their platform. So it is available. But unfortunately, some of these really more, where we're trying to have to do a lot of coordination, we normally tend to start them sort of having few centers participate, and then we can expand. But we would obviously love to bring it to all the patients, with also our partners in Europe. But this particular trial will first only open in the US. And maybe, Shannon, this would be a good question for you, or also maybe for Sarah and Tab. One of the questions was, what research is being done to help with recovery from posterior fossa syndrome? Which I think is an excellent question.
There's not a lot of specific research being done, but I think the importance of immediate, intensive speech and language therapy, occupational therapy, and physical therapy, depending on what the issues are from the very beginning, and really allowing that to continue for a long period of time, and really following that from a perspective of change and improvement is really important. So I could say that actively that is what can be done about it. There's other, from a more surgical perspective, I think there's probably some research being done, but I'm just not as familiar with that literature. I'm sorry.
And I'd have to echo Shannon that we're not surgeons, but I completely reinforce that approach of trying to be multidisciplinary and intensive, and from the family standpoint, as supportive as possible.
Yeah, and I think as pediatric oncologists, in many places, we don't necessarily come into the picture till after the surgery. And so one of the things that's been a real plus of what we've tried to do with the PNOC trials is try to collect information, for all the kids that are on PNOC trials. And we do, it's not a medullo-specific trial, but like in our trial of chiselaricide or tumor paint, we're actually getting some of those quality of life data actually from before surgery. Usually like right before surgery, sometimes hours before surgery, but and then in that early period after surgery to try to actually, it's one of the things that's really not based on the intervention itself so much, which is looking at imaging to help with surgery, but just because across PNOC, we've all been wanting to get more information about really how are the kids doing in these critical things. And so some of the information we're getting there, we actually hope will be helpful for the kids with medullo that are on that trial to shed some light on at least capturing data, because I think even what we call posterior fossa syndrome is really variable, and it's been one of the hard things as a clinical trialist to try to say, do we even understand the data we have?
And I would say too, as parents, certainly what's a change. And so advocating for those things, even if it's dismissed, I don't think you should ever not bring it up, because it is real. And even if the language is getting better, but it's still not improving, it's absolutely important to advocate for the need for an evaluation from a speech and language therapist, occupational therapist, physical therapist, beyond just also the hospital stay. Those are things that are certainly available. If you have private insurance, they're available that way, but certainly if you don't, there are certainly things for children. It depends on state, but there's absolutely services available through regional center and or general state run funding and programs for those kinds of supports and services. So they are available. And I would really also echo that they're different than school-based services, and you really want both.
Great. Yeah. So I think not much in terms of an oncology intervention for posterior fossa syndrome rather than supportive, but I think that would be also a good question to ask our neurosurgeon. So we can maybe get back to you after reaching out. The other question, I think that would be maybe for Sarah and Tab, and then I can chime in as well, which I think is often what families struggle with. So how does a parent get a newly relapsed child into a trial? And I think that obviously will depend where you are and the country you are. But if anyone want to comment on this, I think that would be great.
Sarah, do you want to go?
Sure. I mean, I think that's certainly one of the challenges, that we, even at large centers that have a lot of trials, how to help parents kind of go through that information and decide. When you're just trying to search the web, I think one of the things that's required in the United States is that trials be registered on clinicaltrials.gov, and that's actually a pretty functional way to look for things. But I think it is often really partnering with your physician, even if they don't have a lot of trials there, because they may be connected to sites like PNOC sites that are major brain tumor centers that would have more trials available and be more involved in that split between the research and the clinical side to be aware of what's out there. And then it is how to actually get a child on trial is different for different trials. PNOC, we do that centrally, so you don't have to call all 25 PNOC sites to see if there are spots. Like the trial itself would have the number of spots. And it's a lot of things that we've talked whether we should have a group in PNOC to even help to provide those consultations. But I think at each of our institutions individually, we do things like have a brain, we in Seattle, and I know UCSF in Boston have similar things where we have a brain tumor board where we're happy to do second opinions and kind of let people know who may be coming from smaller sites what kind of trials we think are out there or that we would prioritize if they were our patients. So.
Have anything to add from your end?
No, I largely agree. I think if the PNOC sites are not your home institution, I think trying to reach out for an opinion from anyone from those centers would really be in your best interest, because any one of these people from these sites are going to be able to convey for you what the current landscape is of clinical trials for recurrent Medullo, and not just for PNOC, but through other consortia, and send you to the right place. And what's fortunate about this field is the rarity of the disease. Everybody knows each other. Everybody communicates with each other. If you're somewhere else, but you want to get connected to a certain city, your doctors are going to reach out on your behalf and help facilitate that communication. So advocate for that if they're not already doing it. And then just try to get in a sense for yourself of how far would you want to go and what would you be willing as a family to do for a trial. How invasive is it? How frequent are the visits? What would be the expected side effects? What would that look like for your family in the months to years ahead? Those are all just general things to be thinking about. And the answers to that are not right or wrong. They're very unique for each family.
And I think the only thing I would add, and I fully agree with what Sarah and Tab had said, I mean, normally when, always try to reach out and get a second opinion, because we all are aware of most trials, but we have sort of maybe different viewpoints. So I think that would be my number one advice. Don't be shy to ask for second opinions. Most of our centers really offer that, and through telemedicine, it has been easier to connect. I think the one biggest challenge is really for international patients. So often insurance doesn't cover. Sometimes we get lucky and the local government covers expensive, and I think that that's really something to balance. I mean, there are foundations and we can connect families with foundations who can help support, but that's sort of really the questions that need to be answered. And depending on the phase of the trial, risk and benefits, I think, need to be carefully weighed. And like Tab said, that there's no right or wrong. It's just sort of a very personal preference. Going to the next question, I think I'm going back a little bit, Rob, to more, there were two basic science sort of questions. So one was, have you contemplated growing cells from tumors in mice to use that for further testing beyond the 175 drugs? And then with the lab tabs that are promising, what are sort of the next steps you can envision for this type of therapy?
Sure, I was actually typing an answer, but I'd rather speak the answer to the first one. So the answer is, we do routinely take cells from the tumor and implant them into the brain of a mouse so that they can grow and we can use them for further studies. This is called xenografting. And when you put it into the brain, it's called orthotopic xenografting. Sarah has done this, Sarah's lab has done this as well as a number of other labs have. The challenge is that with relapsed cases, sometimes there's not enough tissue to be able to do all the things you want to do. And if we prioritize the drug screen, there may or may not be enough cells to then implant into a mouse. The other issue is that when you put the cells into the brain of a mouse, they tend to take several months to grow. And so using that as a way to guide therapy is really not necessarily practical. But using it as a way to test hypotheses, to test further therapies is really valuable. And it's a resource that we really try to build up as much as we can in our own lab and then share with other labs around the country and around the world. And as I said, the medulloblastoma community has been very collaborative. So between Sarah and Jim Olson in Seattle, Xiaonan Li, who is in Texas and is now in Chicago, and a group at St. Jude, for example, we have access to probably over 100 xenografts now that can be used to study medulloblastoma. So this has been an incredibly valuable resource. For the lab tests that are promising, I would say that there are a number of genetic markers that we know are associated with either favorable or poor prognosis in medulloblastoma. P53 is one of them. In the context of patients with hedgehog tumors, P53 mutation is a marker of very poor prognosis. And it's not that we have a therapy that we can necessarily direct at those patients, at least not yet, but that is a marker, a biomarker that says to us, this is an extremely aggressive tumor. We need to treat it aggressively and monitor the patient very carefully. So I think that the purpose of studies like the PNOC 027 is really in part to, in addition to finding the best treatments for patients, it's to glean what biomarkers we can use going forward that might predict outcome or might predict responsiveness to a particular therapy. And I think we're still not there yet in terms of knowing which biomarkers dictate which drugs we should use. So I hope that answers the question.
There are some really good questions and some great answers. We want to actually introduce another panelist because I think that it does really kind of bring all of this to home. Someone that is near and dear to my heart, and their family I've grown to know over the last couple of years. It'd be great to hear from patient family, Barbara and Steve Karsky, because they could share a bit about their journey, some of their insights. And it's been some years since their daughter's actually been treated, so she might be able to share some things like that. And I know that we're getting some questions, which are great too, about late effects. So that might go well into Sabine. We could ask those questions after from you. So Barbara, if you don't mind, are you and Steve still there?
Yes, hello. So Steve actually just got called from Mila from school. She demanded an early pickup, so Steve will be back in 10 minutes. But thank you for having us here. I'm glad to participate and share our experience. So my name is Barbara Karsky, my husband is Steve, and our daughter Mila was diagnosed with medulloblastoma at the age of 5 years. I think 5 years and 2 or 3 months. Happened in February 2017. It was high-risk medulloblastoma, which had spread to the spine. And we had emergency surgery the very next day. And a large part of the tumor was able to be removed, but because it had kind of tangled itself across different nerves and this brain stem, not everything was able, we were able to retract. After that, we basically we're given a choice between the, standard treatment, which is usually radiation first, followed by chemotherapy. And then we were at the Children's Hospital in Oakland, which also offered Head Start 4, which is a trial that's been around for quite a while. And basically tries to address or get rid of the tumors through really high dose chemotherapy. And then potentially, if not successful, you still have the option of radiation afterwards. So that is the journey that we embarked upon. It was about an 18-month journey that we went through. We had 8 rounds of chemotherapy, which were Yeah, high dose. We definitely had methotrexate as part of the first 5 cycles, which was pretty rough. The first cycle, especially, Mila ended up in the ICU. But yeah, as with everything, you know, in humans, kids especially are just amazing. And we got the hang of it. We got into a routine. We tried our best to make it as sorry, as fun and least painful for Mila. And you know, by the end of it, she was she was an expert at going back to the hospital for her next round of chemotherapy. We had some cycles that she just breezed through, so it was really a very different bag. Most cycles actually ended up being not too bad. And then, yeah, so we had 5 rounds of high dose chemotherapy, and then we were randomized to have 3 rounds of stem cell transplants as well, which was also very interesting and an experience. We needed a lot of prizes to get Mila through those because it involved taking showers at night and really they were at, you know, all hours of the day. So yeah, we got through that. It took about 12 months. We were more inpatient than outpatient. After, I think, the second round of chemo, where we tried to go home in between and had several complications, we actually chose to stay inpatient. It made things easier. We felt safer and more supported, of course. So yeah, we got through those 8 rounds of chemotherapy. It helped to reduce the tumor, but it didn't get rid of it completely. So at the end of the year of chemotherapy, we didn't really have a choice and decided to go for radiation. We also, well, we ended up in Boston, where Dr. Cooney is now, and did proton therapy radiation, because we saw the advantages of proton, of, you know, having less side effects to other organs, as the spine had to be radiated as well. I guess the advantage for us, or the reason why we chose Head Start 4 over radiation as a first treatment option, was really to delay the radiation if necessary. And I guess we achieved that. We achieved the goal to at least delay it by a whole year. So Mila was almost 6.5 by the time radiation started. So it was, you know, a long time after the first diagnosis. And, you know, her brain was developed more, plus also because the tumor had shrunk, we were able to go with a lower dosage of radiation, which at least to us felt like a win at the time. It was a very hard decision at the time to really decide what dosage of radiation to go with. But radiation seemed like a walk in the park after chemotherapy, we have to say. But, you know, when we think about the long-term effects, it's definitely a different bag. We were lucky enough that after radiation in July 2018, we got the all clear. Mila was cancer-free. Sorry.
You don't need to apologize, Barbara.
Even 3 years later, I still don't get through this without getting emotional. So,
of course, we're 10 years out, and I still get choked up when I talk about it. You know, very emotional to go back to that place and those times. And, you know, there's families that are on the call right now that are actually right where you were 3 years ago. You know, so this is so valuable for them.
Yes.
Yeah, so, you know, we consider ourselves very lucky. And Dr. Cooney was actually our doctor. She was in Oakland at the time, and she was the one delivering us the great news in July 2018 that Mila is cancer-free. She has stayed cancer-free. It's now been almost 3.5 years. So we're very happy, of course. And for those of you who are in the middle of it, you know, MRI check-ins do get easier over time. It was very nerve-wracking in the beginning, but we are a bit more relaxed now. They're now spread out to every 6 months, so that is great as well. But yeah, you know, as was mentioned earlier, radiation especially has a lot of long-term effects, and we are living through those on a daily basis today. I mean, right now, what I would say is the picture that was painted to us at the very beginning, when we were deciding between the initial treatment and, you know, the drawbacks of early radiation, it sounded just, you know, terrible of what effect it can have on a child. And, you know, our experience so far is actually that Mila is doing so much better than we thought. She, she missed kindergarten. She spent that kindergarten year in hospital, but she joined first grade. We're definitely seeing slow processing speed. Dr. Lundy is actually our neuropsychologist, who we have the pleasure of seeing every now and then. And yeah, so learning to read and write was hard, but Mila is doing a good job. She seems just as smart as before. It's just things take longer. There's also, of course, the hormonal deficiencies that have kicked in about a year after treatment end. So I would say the first year seemed really just great because there was no more medication, no supplement, no need for supplements yet. Mila was, getting stronger and stronger. And then, the longer term effects start kicking in. So, the hormonal stuff is relatively easy to go through every day. I mean, the growth hormone is daily injections, which, probably no child enjoys, but again, kids just get used to it and they become experts. We have other long-term things, like Mila had iron overload in her blood from all the blood transfusions that she received during treatment. So that was a 1.5 years of getting IVs placed every other week to take blood out, but we've just finished that a few weeks ago. So that was a huge milestone, a very happy moment that we don't have to do that anymore. But yeah, I mean, Mila is now starting to get to the age, she's about to turn 10, where she's realizing that, things are a little bit different for her than for her classmates. And so I think there's more on the psychological side, there's more things that we're going to be going through in the next few years. But overall, she's just, a very happy 10-year-old. She is, probably a bit more protected than other kids. So she literally still believes in the tooth fairy and Santa Claus. We were at the hospital for an MRI check-in, I think this past Christmas, and she filled out a form that was provided at the reception for the kids to make a wish list and a letter. And there was a special Santa letterbox, and she made a wish for a kite, and lo and behold, in her stocking on Christmas Day, there was a kite. So that's, reinforced her belief in Santa Claus. And yeah, I mean, again, we consider ourselves very lucky in where we are today. There are things that you have to handle and deal with, of course, long term. But we're just, of course, happy that Mila is with us and we get to experience all those. I'm really looking forward to the teenage years and puberty. I can't wait. Yeah.
Oh,
Thank you, Barbara, for sharing. Yeah, but based on what you just said, there are two really good questions, I think, from the audience, and love to hear what Tab and Sarah, what you have to say. So the question is, for these long-term side effects, is there a good database sort of tracking the impact some of the therapies we offer, like physical therapy, occupational therapy, other sort of medications intervention, really for these more long-term side effects? Because to my knowledge, I don't think we really have that, and we don't track that well. And so I wanted to get your thoughts on that.
Sarah, would you like me to start?
Yeah, go ahead.
So there's some things out there, but they're limited. I would say the childhood cancer survivor cohort study, Sabine, I'm butchering it, CCSS, right? Childhood Cancer Survivor Study, run through St. Jude, has the largest epidemiologic database of survivors. So it's followed many childhood survivors over the last several decades. But what data they have collected and are collecting, there's room to improve. They're still trying to, but things like ongoing therapy, I don't believe are readily known through this database. It's more about what they've been able to show over the recent years are the actual late effects and toxicities. But what you're wanting to ask are large databases about really interventions and interventions that work. And I think we have a bit of a way to go. I would say just as a plug for what we're trying to study here at Dana-Farber Boston Children's, I think we know that medulloblastoma survivors, there's a large portion of them who endure physiologic frailty, a little bit lower muscle mass, lower energy, walking limitations. This frailty can be linked long-term to morbidities and death, and it's a big risk. And so what we're trying to study and intervene on are ways to improve strength and resilience for these people. Really, that's something that should start at diagnoses, but through finances and processes, I think it's going to take time before you see that implemented largely. But we're trying to develop exercise interventions and more holistic measures to try to get at this. Sarah, do you know? I mean, I'm a very large proponent of all these therapies, but if there's data out there.
No, one comment I was going to make is really what a lot of the clinical trials are not, is actually having the ability, or even, even from the Children's Oncology Group perspective, I mean, within the CNS committee, we're really charged with studying treatment. And to the point of it sometimes being quite frustrating, because even the long trials that go on for 10 years, we're actually stopped at 10 years. And sometimes that's where we're just starting to see things. So if you talk about some of those trials with the survival curves you showed, there was an argument amongst some that even predated me to say, you know what, we're just starting to even see second malignancies and some other things that we really want a better sense of. And so we have, 1,000 kids treated in the last 10 years almost on COG medulloblastoma trials. And that's a cohort, we know who they are, and I think there's opportunity there, but they're very much not, these things we want to know about what happens after is very much not a part of those trials, not what the NCI is funding for. And I think how we as a community think about going after the information we want. There are trials of interventions, and I think there's more of those coming. And I think using those networks like we have in PNOC and COG, and so those kind of things, as Tab mentioned, things like looking at exercise, strength, what to do during and after that will predict more health. Those kind of trials are actually being conducted. But to even kind of know the data, know where we are, I don't think we should lose the data of how the kids are doing that went 10, 20 years ago, right? Because there's a big group of cancer survivors, and we need to look at that more. One of my favorite quotes, I'll say, one of the psychologists I worked with always said, I'd rather have a kid who gets some radiation and whose parents have been in the hospital still reading to them every night than a kid who gets neither. And I think we all sort of see that to be true. There is a lot you can do. And part of it is also just not giving up all the things we all know we need to do for kids as they're growing up, but to try to do it and layer it on what was beautifully described of how crazy it is to go through therapy, we think is really important, but we want more data on how to do that better.
Great, so we are coming close to the end, but there are definitely some few questions. So maybe, Sarah, Tab, do you know if anyone is studying options in treatment for medulloblastoma that goes outside the CNS, like when we see it in the bone marrow or bones specifically? Are you aware of any dedicated trials? I'm not. No
dedicated trials.
Yeah.
I mean, certainly sounds like a systemic approach would be necessary. Sarah, do you?
But no, and I'll tell you, one of the things we say a lot about this is we actually think those might be the cells even though it's unusual and we probably should get a better understanding of the biology of that, really where we often fail is in the CNS. And so I think if we had a working drug, it should not exclude those patients that have the rare patients that have tumors go outside. And we see that more commonly in, just anecdotally, I will say, in young adults and sometimes in the hedgehog type, but we're still failing in the CNS if there are cells out there. That's kind of my bottom line, is that what we really need is drugs that work on the biology of medullo. And if they work and we're giving them as a pill or systemically, they hopefully will work outside at least as well, if not better, because the drugs get there better.
Yeah, and I apologize. Alan just reminded me we have a little bit more time. We are going until 2:30. Great. There was another question which I think comes up quite a bit in sort of a management. Any insight, and I think I will direct this really to Sarah and Tab again, for treating radiation necrosis and the role of Avastin and any limitations on the use of Avastin, if you could maybe comment how you handle this and your experience with that.
Sabine, you might have more experience than me with this. I've certainly given Avastin. I wouldn't say I've encountered much radiation necrosis for my Medullo patients, more so with the high-grade glial. Have either of you encountered with Medullo?
Yeah, we have, and one of the things I worry about is even though we're trying to give less radiation, particularly with kids who get now much more intense chemo and then radiation, we may actually be increasing the risk of that. There aren't as many kids in the world that have been treated, actually, as the child was described here, right, with very intense chemotherapy, high dose therapy, methotrexate, and radiation. And so I do worry just anecdotally that in the small trials that have been really, really aggressive, we may be seeing more, even if you only give focal radiation in some cases. We do use Avastin. We don't use it very long term, and we do have worries about bone growth and other kinds of things. But I mean, with our patients with radiation necrosis, we absolutely would use Avastin. I think that's in my mind. Side effect wise, I'd rather use Avastin than dexamethasone, which we often use immediately, but then try to transition to something else. But I will say it's not a perfect treatment, and we're often using Avastin or having families seek out other potential effective therapies. I'm not sure that we really know we have an effective therapy for radiation necrosis, and so I come back to the biggest focus is on how can we give fewer and fewer kids radiation.
Yeah, I would agree. I mean, I think we definitely see it in other settings more frequently. Also, our approach has been, I think, Avastin in the short term is often very well tolerated. I mean, sometimes we are worried, especially if radiation necrosis occurs in the setting of a second round of radiation, that sometimes we can see the risk of bleeding. I think that is a concern, but normally my go-to would also be first Avastin, but I limit normally 3 to 5 doses. Obviously, then if a child does extremely well and has no side effects, I mean, there's always the question, should you stop, should you not? But then another approach we have been using then, instead of giving it every 2 weeks, which is sort of our standard schedule, maybe even delay or doing it every 4 weeks, giving a slightly lower dose. And then the question of hyperbaric oxic chamber, I mean, we don't use that routinely. I mean, I think the data is controversial on that. So we personally, or at UCSF, we don't use it a lot for the treatment of radiation necrosis. And then besides really Avastin, I'm not aware of any other really treatments that we are currently offering for that. And I would totally agree with Sarah that I think Avastin is reasonable to try, but it's often not a great solution. And so I think we're still really striving to avoid radiation in the first place if we can. And I think for all the above reasons, including obviously the long-term side effects.
I do want to acknowledge that Steve is back and he completely missed Barbara's wonderful sharing of Mila's journey. Steve, she did a great job.
Thanks, Dr. Kinney.
It was very wonderful to hear how she's doing now.
Thank you.
I think another really interesting question when it comes sort of to a therapeutic approach that was asked, sort of if you could share your perspective on maintenance chemotherapy after a radiation sparing protocol, how do you sort of weigh benefits and risk? Maybe Sarah, you can start.
Yeah, I was going to say I've had this conversation pretty frequently. So where we, it's one of the questions we actually hope to study at the next trial. So what is the benefit? We have, a lot of us use the 3-drug regimen in the event of recurrence, which is temozolomide, irinotecan, and bevacizumab or Avastin, just because that combination has at least as good, if not better, results across the spectrum of recurrent Medullo than anything else we've tried in a big trial. And it's usually tolerated, and for a lot of other reasons that we commonly use that. And so the question is kind of obvious that if it seems to work, at least for a while, in people with recurrent Medullo, what if we added it on? And we honestly don't know. And there's certainly been other trials with that philosophy of what if I gave more on top of this that haven't worked. And so we really don't know if you give it to someone who's finished all the standard therapy earlier, would that prevent relapse? And that's going to be something we try to study on the next generation of trials. For what I do now, again, kind of not knowing if it's going to help or not, it's really when we have used it is the kids that have gone through like an infant approach have not responded entirely, and we're very worried, and yet they're still so young that that balance between, you know, knowing radiation is effective, it still may not be the best thing for them. And then that's where we go kind of into the unknown. And I have had kids where we've tried to do that. One of the big questions we still need to answer is how tolerable is that? You can't just give it full dose because your blood, you know, you don't recover as well after all of that chemo and then more chemo. But we have done it a few times in that setting. I certainly think it's very reasonable to discuss. I don't do it across the board, and because again, giving toxic therapy with no known benefit is sort of against the first do no harm principle of what we're trying to do here. I don't know, Tab, if you have different, we do talk about this a lot, I think, in our field about should I do something more? And I will say psychologically, one of the hardest parts of therapy, other than finding out your kid has a brain tumor, is stopping therapy and going into that watch for all of us. I mean, parents, I will say more than us probably, but it's a hard time, you know, not doing something and waiting for those MRIs, as mentioned, call it skin anxiety.
Yeah, no, I would agree with you. I think it's an unanswered question, but it's a very important one, but it's also challenging to answer, right? You need to have basically a randomization strategy where then patients will be followed after the initial therapy versus patients who will be treated. And that's always challenging to implement in pediatrics, I would say. So it's a great question, and we would love to know the answer, but I think we're clearly not there as a field. Rob, maybe a question for you. So the question is, have you seen drug resistances or tumor recurrence under chemotherapy, which I think we all have seen. But the question is then, you know, and this could be maybe twofold also for maybe Sarah and Tab on the clinical grounds. How do you best study this maybe in the lab, and then also clinically, you know, how could we get to this recurrence or resistance to chemotherapy, and what to do next?
Yeah, it's a really great question and a really big problem. You know, I think that the majority of patients who are treated for newly diagnosed medulloblastoma respond to radiation, respond to chemo, in that the tumor is held at bay or shrinks. You know, I think the big challenge is when that tumor comes back, then patients are often resistant to the therapies that they got up front. There are ways to study this in the lab, taking some of the models that we've developed, either genetically engineered models or patient-derived xenograft models, where we put patient cells into a mouse, treating them with standard therapies, including surgery, which is very challenging in a mouse, including radiotherapy and including chemotherapy. And then when the animals relapse, then we can begin to study what happened to those tumor cells. There have been a few studies of this, but it's been really, really difficult to figure out the mechanisms of resistance. Typically, if the mouse, and presumably if the patient has been irradiated, the tumor acquires new mutations, and those are they could be mutations in a variety of different genes. P53 is an example of a gene that's not mutated that frequently in newly diagnosed medulloblastoma, but is found to be frequently mutated at relapse. But I would say we don't yet have, from the basic science studies, strategies that we think would be effective for treating relapsed medullo. And so this is part of the point, again, of you know, doing a capturing tumor tissue at relapse, subjecting it to drug screening, subjecting it to genomic analysis, and really trying to learn, you know, what are the things that we could try that might make a difference at that stage.
Yeah, and I think clinically, right, when you're trying to get at those, it would require, you know, another biopsy. And I think that's often what I think the field is changing, and that we are offering those to really understand the changes we see in the current tumor. And it's something that a lot of centers are now contemplating. And I know, I think, Sarah, right, within your group, right, you tend to offer a biopsy of recurrence, because we are often surprised that in the recurrent medulloblastoma setting, we then encounter when we biopsy that this is actually not recurrent medulloblastoma, but often, depending on the prior treatment, radiation-induced high-grade gliomas. And so I think overall the field is definitely moving towards offering biopsy at time of recurrence. We know that these can be done safely. I mean, it's obviously an additional procedure for the child, so we don't take that decision lightly. But we know it's really impacting our therapy decision. And I think especially in medulloblastoma, we learned that many times we actually don't deal with recurrent medullo, but we are dealing with really a more radiation-induced subtype. So, and then when we take that tumor tissue and compare to the initial tumor, we obviously can learn a lot using sort of a newer technology that Rob discussed, next generation sequencing, to really understand what is the resistance. It could be to radiation-induced changes, but also to the chemotherapy. But it's an ongoing field. I don't know, Sarah, Tab, if you have anything to add here.
Yeah, I think it's a personal decision. As you mentioned, we offer biopsy of recurrent tumor as long as our surgeons feel like it's safe to do. And we partner a lot to have that conversation about risk. It's obviously upfront, we need tissue. And, at relapse, it's harder because I can't promise someone that the likelihood of cure is nearly as high, or that we're even going to find something beneficial. But I think, with the right counseling, it's a personal choice with families, but I think the ones who do decide biopsy feel like even if we may not be able to cure this child, we want all the information we can get that we might use with decision making about what to try, and then of course, it obviously collecting that data helps for the future as we learn more about as many kids as we can. I would use that data personally if we find something that's potentially targetable, for sure.
I wonder if the panelists might talk about the use of blood biomarkers that may help assist in diagnosis and prediction as well.
And I would say not blood, but CSF. That's another major area of research for us. Well, right. The reason I say not blood is for us, blood doesn't work yet, but in our hands, we can see the molecular changes in the tumor in spinal fluid in about 50% of the time. And so it's a really active area that I'd like to translate into clinical use much more broadly as quickly as we can. So hopefully then you don't have to agonize so much. We can get some biology data in recurrent tumors in a much
and as part of the answer, I don't know who's going to answer that, but to talk about heterogeneity, because it's not one single tumor type in that tumor, correct, right? Because that influences how patients might respond to single drug, 3 drugs, 4, whatever. If maybe somebody would address that as well, that'd be great.
Yeah, I wrote an answer to that question, but I'm happy to sort of give a short version of the answer to that question, which is tumor heterogeneity is a big problem. It's when we take out a piece of tumor and we sequence it, we assume that the whole tumor has that mutation, and it doesn't. So it's a problem for any kind of analysis we want to do. I think that going forward, if we're able to capture multiple pieces of a tumor, we can certainly analyze them separately. And when this has been done, it's been clear that there is some heterogeneity, not quite as much in medulloblastoma as in some other tumor types. But I think that we have to be aware that there's a limit to what we can glean about the whole tumor from the small piece that we capture. And that's just a challenge that we have to face. There are a couple of questions. I don't know if you want me to address these related to the molecular genomic characterization versus the histological characterization. For example, does large cell anaplastic medulloblastoma still mean something? And there are no pathologists on the line, I guess, but I will come to their defense and say that looking at the histology of the tissue still makes a big difference. It's still really important to know that there are large ugly cells or that there are small round blue cells. But I would say that molecular analysis goes hand in hand with that. And so the tumors that we used to call large cell anaplastic are very often the tumors that are group 3 that have MYC amplification. And when we look, if you had to pick one of those criteria, MYC amplification is probably more predictive than the large cell anaplastic histology. So I think going forward, we're not going to throw any information out. And at least the pathologist at our institution is very much on board with melding the traditional histological analysis with what we can glean from molecular profiling. And as molecular profiling gets more and more sophisticated, I think we're going to learn more and more about that.
I'm just going to jump in here and firstly welcome Dr. Michael Prados for joining, co-founder of PNOC. Great to have you on, Mike. And maybe you can actually address this question that you might have seen in the chat. It's one that's near and dear to me as part of the foundation, and that is funding. You know, where is the biggest need, and how can the parent community help with funding awareness?
The biggest need. So it's everywhere. That's too simplistic to say. I mean, 90% of what we do within PNOC is philanthropy funded, family funded, foundation funded. And I think everybody on the chat probably understands that the percentage of what the NCI, National Cancer Institute, at least in the United States, parcels out for pure research in pediatric tumors and pediatric brain tumors is a very small amount in terms of the budget. So there's a disconnect between resources available and the need. So the trial that Rob just talked about, using high throughput drug screening, right now we can afford to do 10 patients. And that's because it's all philanthropically funded. And we want to do more, and we want to do more quickly as well. And so there's a lot of need. And I think you've heard all of the challenges. The solution to those challenges is going to come from the laboratory and from clinical research. I mean, there's no question. And then also from family engagement who participate by adding information to a larger database that we can link patient level data to the laboratory and the clinical and translate all that into something that's meaningful in the short term. So I think that the plea is always to give, but I mean, I think the other plea is to stimulate funders on the NCI part as well as every place else to be a bit more engaged in funding this kind of research. We talk about years of life lost. That's a phrase that people use. Children who die young have much greater years of life lost than other people. If I died today, I may lose 10 years, but if my child or my grandchild died today, they've lost 70 or 80 years of life lost. So those kinds of formulas, there may be statistical, but they're meaningful. They have some gravitas, right?
Mm-hmm.
So I think that we need to be very cognizant of the limited amount of funding to address any of these questions that we've talked about today is not enough. It's not enough. And it's just going to take longer. And the longer it takes, the more we lose, the benefits that could have come if we had done it sooner and if we had the resources to make that happen.
Mm-hmm. And I would just add, Mike, just as, PNOC is a bright, shining star in terms of setting an example of what can be achieved through, collaboration and breaking down walls and sharing information in real time. The pediatric brain tumor community needs to be collaborating as well in terms of raising awareness and raising more funding. I mean, the simple answer is we need, as a community, we need to raise more dollars to actually, fund and accelerate this incredibly critical research. And one of the biggest frustrations that you run into as a parent of a patient who's had a pediatric brain cancer is when you realize the doctor who's treating your child is also spending time trying to find where the next dollar's coming from to fund the research that they're doing to save your kid. So that's got to stop. There's other people who can raise money. We've got to stop the doctors and the researchers from, really wasting valuable time that should be spent on the science, trying to find the next dollar. PNOC Foundation, part of our purview is to help facilitate and raise money to support the foundation. We've been an intermediary as well as a public charity 501c3. We've been an intermediary for directing funds to PNOC, and funds can be given on a restricted basis as well. So if you wanted to give funds that were particular to a trial or to supporting research of a particular tumor type like medulloblastoma, we can facilitate that as well.
I just want to also just emphasize again, sharing information, patients sharing, parents sharing information about their child, genomic information, outcome information into databases that can be collectively viewed quickly is another really efficient way to increase the efficiency and the rapidity of research. There's no question about that. And they're actually that kind of strategy of engaging, that the community, right, the stakeholder community into this information sharing and gathering is now going to be embedded in our clinical trials to try and understand, what we're doing right and wrong a lot faster, because these are rare diseases, thank goodness. But that's also a way of resource sharing. I think it's important to emphasize that as well.
I think one important point to make, especially I think for medulloblastoma research, and I think we heard this a lot today, there's really no good funding mechanism from the NIH or other fund. Like our grants normally go 1 year, 2 year, maybe 5 years. But if you really want to study these long-term side effects, this is extremely challenging. I mean, we started now a long-term follow-up protocol within PNOC as well, where we really try. I mean, in the end, I would love to sit here in 20 years and say for every patient, we have 20-year follow-up. But there's really no funding mechanism for this because, funding agencies, especially the NIH, they want to see outcome right after 5 years instead of the max length. So I think from that perspective, and I think it was really highlighted by a lot of the questions that were posed today by whoever one is participating in this webinar, that we don't have a lot of great answers, right? How much is physical therapy, occupational therapy really helping? Because we don't have great mechanisms to collect these really long-term data because there are really no great funding mechanisms. So I do think, in addition to obviously supporting research that helps develop better therapies, I also think there's definitely for medulloblastoma also a strong need to support some of this late effect research and how we actually capture that.
So I know we're coming towards the end of time. We might have time for one more.
I think there's a really timely question, and Tab, I will let you answer that. So now that COVID vaccine will be available for the kids in the US between 5 and 11 soon, would it be beneficial for children diagnosed with a medulloblastoma to get the vaccination? And would you recommend this? Would you also, maybe Tab in general, you can comment on your thought process on using the COVID vaccine in your patient population, on treatment, off treatment?
I want everyone to have the vaccine. Everybody yesterday needs to have the vaccine. So if the federal agencies are saying it's safe to give it and your child's of that age, of course, talk about it, please, with your primary healthcare providers. But we do think there are going to be healthcare risks to them from getting the infection or from one of their family members getting the infection. There's such serious consequences of the disease that we really are, I guess I can speak for all of us here to say we're very strong proponents of vaccination.
The analogy I often use is I showed you some data that changed our practice that was based on 25 patients. We have data on thousands and thousands and thousands about how beneficial this vaccine is. And to watch some patients who couldn't get the vaccine go through therapy or even after therapy with the virus has been horrific. And so, yes, this is something we can change that we know the answer to now. So please, I'll echo what Tab said. That's where we are in the vaccine.
Even during active therapy.
We do.
And then we have to discuss, obviously, what will be booster strategy, and that's data that's coming out. But I think what you clearly hear strong yes, anywhere, at any stage where you are during treatment. If it's approved, we would definitely recommend it. Mike, one quick question for you. Any studies that you're aware of for adult patients with medulloblastoma?
No, we've tried across the years to do something like that, but it's been a very unsuccessful. Adults are treated like children. This is very interesting because it used to be that children were always treated like adults, but it's different in this context. And the disease is different in adults, right? They're often sonic hedgehog, and P53 may not be as important in those patients where it is in the younger children. So I think it's a different disease. It's not studied well. About 20% of medulla or so are in older, I say older, in 20 and 30-year-olds. So it's still a bit of a black box. I think they all should be put into the same box though and studied carefully. I think that adult AYA, we talk about AYA, I think the people who treat medulloblastoma in this panel can treat a 20-year-old and a 30-year-old. And I think they have the expertise and the knowledge and the way to look at the data. That makes better sense, I think, for it to stay within that community of researchers.
Maybe two last questions, but I think they are on a lot of families' mind. Is there any data showing that growth hormones cause medulloblastoma relapse?
No, and the data that I'm aware of, it was a long time ago because it was when I first got into this field. We absolutely replaced growth hormone in kids that need it. It's part of that, again, sort of where we're focused on kids growing up to be adults. And there is some data. It wasn't a clinical trial, but it was looking back. When you look at kids who got growth hormone compared to those who didn't, the survival was actually better in the growth hormone group. And that may be because they were getting better comprehensive care. So I'm not sure that's causative, but at least no concerning signals that I've ever seen when we've tried to look at that.
Dr. Leary, related question then would be, how soon after the completion of therapy, or at what stage of therapy, would you recommend that growth hormone treatment start?
Oh, we recommend it when it's been identified. So we work in partnership with the endocrinologist. It's usually, as was described for Mengele, it's not usually there until it's a later effect. So it's usually, you're only really at risk generally starting like the year after you've had radiation, and radiation is the biggest association with growth hormone deficiency. So we check it routinely when we do the routine follow-up every 3 months or every 6 months when we're seeing the kids. But it's really an endocrinologist following their growth. So there's not a perfect lab test for that one. We partner with the experts who, it's not where my expertise is, but I have an endocrinologist that I work with who sees the patients with me and looks at their growth charts every time and kind of makes that decision with the family. It's not an emergency, which I'm not as used to because most of what we do is an emergency. So it's sort of in careful consideration, but you need growth hormone before your bones fuse if it's going to be beneficial for a lot of the growth. So it can be made over a few years about, do you need more or not? But there should be no restriction in my opinion on using it.
I would say most endocrinologists, at least our practice, has been about a year of therapy. And then if you want to start it earlier, it's a very sort of individual decision, but that's sort of, I think, what a lot of endocrinologists use as a time frame. So one question, and I know we're coming to the end here, but can you speak towards why a child with metastatic medulloblastoma who is in remission is at significantly higher risk for relapse than an M0 child?
It actually, individually, nobody has a percentage. So this is where I think it'd be really useful to mention that, we use percentages to talk about populations and get as many kids as we can that are like your child. A child is not an 80%. That's not an individual number. And that's a really hard thing with cancer in general to think about. But, a child who has M0 non-MYC amplified tumor that's had a complete response and is doing well 3 years later is at really low risk of relapse compared to somebody who's been more recently diagnosed and may have there are a lot of risk factors, and metastatic disease is one. But again, no good or bad tumor, it's very, very individual. So that's the way I think about this. And again, if we could change the risk, we would. And so we do those things we can, to tailor therapy. The most important predictor of survival is that you got the right therapy for you. So that's how I think about it. I don't know, Tav, if you have other comments on that.
No.
Yeah.
So I want to pause at this point and, coming up to the end of time, and give ourselves a little bit of time to wrap up here. First, I want to really thank all of the viewers who joined us today, and we hope that you found the panel's discussion and the Q&A of value. I know that I did. I want to thank the panelists who have taken time out of incredibly, busy critically important schedules and the treatment of their patients to join us today so that they could share this information with you as a group. And I want to thank, a lot of the other foundations that support the work of PNOC have supported the medulloblastoma work and also the promotion of the webinar today. It's really only through, collaborating and sharing and continuing to do that on even a broader, greater scale that we're really going to make the breakthroughs that we need to make to actually change the landscape of this disease, whether it's, improving survival or improving quality of life in survival. So, we've got a lot of work to do. It sometimes seems like a daunting task, but, we're up for the challenge and we've got to continue the work.
Yes, I found today's conversation so, incredibly enlightening. And the reason these webinars really came to mind is, if you were to ask us 11 years ago, if we had this particular resource, this amount of information and all of you to be able to tap into, that would have been incredibly helpful. So again, hope all of our viewers have found that same feeling. So I want to thank you all and let you know that this video is being recorded and we'll be emailing you with links so that you can take a look at it again, or if you want to share with another patient family. And if you'd like to learn more about PNOC trials, please go to pnoc.us. And if you'd like to know more about helping support them and awareness, go to pnocfoundation.org.
Thanks, everybody.
Thank you.
Have a great Friday and a great weekend.
Yeah.
Thank you very much.
Bye.